Hello everyone. This is a lecture about ECG and imaging interpretation. Thank you very much for joining this session. So we are very lucky persons when our heart is working automatically, because it has a system, electrical system that is working all the time. In order to diagnose or interpret the ECG, I propose to follow 10 steps. These 10 steps are helping us being systematic. So let's start with the first one, which is the rhythm. In order to find out whether the rhythm of this patient is regular or irregular, we take a piece of paper and we draw the distance. We mark the distance between the two R in the ECG, and we transport this distance to the other QRS, and we compare it. If the distance is permanent, it's all the time the same. We are talking about a normal, regular rhythm. This second one, you can see this is not regular, this is an irregular rhythm, and there are two types of irregular rhythms. It can be a irregularly irregular rhythm, as you see here the example of atrial fibrillation, because it's not following any pattern, it's completely irregular. This third one is a regularly irregular rhythm, because it follows the pattern. You can see it along the strip of the ECG. This, for example, is a second-degree heart block, type 2. So, regular or irregular. Then we go to the second step, which is the rate. For this, we have at the ECG the boxes, the big boxes and the little boxes. One big box contains a duration of 0.2 seconds, and each one of the 5 small boxes inside the big box is 0.04 seconds. So we can, using these boxes, we can calculate the rhythm of this patient. If the rhythm is regular, and only if the rhythm is regular, we can divide how many big boxes we have between two QRS complexes, in this case 5, and we divide 300 divided by 5, so we can reach the conclusion that this patient, 300 divided by 5, this patient has a rhythm of 60 beats per minute. This is only when the rhythm is regular. If the rhythm is irregular, we cannot calculate it using this rule. We have another one, which is the distance. You can see here at the top, these three marks. The distance between the first and the third one is 6 seconds. So you count how many QRS complexes we have between the first and the last mark. That means how many complexes we have in 6 seconds. And if we multiply it by 10, then we will know how many complexes or how many beats this patient has in 60 seconds, in 1 minute. This is for the irregular rhythm. That means that this patient has 6 multiplied by 10, 60. 60 is the rhythm of this patient. So now we know how to calculate the rhythm of the patient and the rate. Let's go to the third step, which is the axis of the patient. The normal axis, you can see it when in lead 1 and AVF, in these two leads, the complexes are positive. This is a normal cardiac axis. If it's different, you can see that here in 1 it's positive, but in AVF it's negative. So I have a mnemonic rule that if they are leaving each other, left leaves. That means if the QRX complexes are going in the opposite direction, they are leaving each other, left leaves. This is a left axis deviation. Left leaves. On the contrary, if they are going 1 and AVF each towards the other, then right returns. They are, and that means that this is a right axis deviation. Left leaves and right returns, right axis deviation. You look at 1 and AVF and you will know whether this is a normal axis or it has a deviation to the left or the right. The fourth step is the P wave. You can see here example of a P pulmonale when a right atrial enlargement is present. The second example is a P mitrale where the P wave has a shape of an M, and this is showing us a left atrial enlargement. So continuing with the steps for interpretation of the ECG, we arrive to the step number 5, which is the PR interval. A normal PR interval should not be longer than 3 to 5 small squares. That means 0.2 seconds. If it is prolonged, like in the first example we see here, we are talking about a AV block, atrioventricular block, because the conduction is prolonged. And we can see here examples of rare cases, Wolf Parkinson-White when it is reduced, or pericarditis when it is depressed. Step number 6, the Q wave. A normal Q wave should not be deeper than 2 small squares. If it's deeper than that, like in this example, for instance, in 2, 3, and AVF, that means the inferior wall, that means a old event that happened, like a old inferior wall MI, because the Q wave is deeper than 2 small squares. Step number 7, we look whether the QRS complexes are broad, too much broad. A broad QRS means a ventricular arrhythmia. The first example on the left is a ventricular ectopic beat. You can see the let's use the laser pointer. You can see that these complexes are broad compared with the other one, and we even can see here a compensatory pause because the beats are premature ventricular beats, and then the heart is doing is taking a break using a compensatory pause. This is a classical example of ventricular ectopic beats, or VPBs, ventricular premature beats. Other example of broad QRSs is the ventricular tachycardia, as you can see here, or the ventricular fibrillation, which is a very frightening situation. Other examples of broad QRSs, or not normal, abnormal QRSs, is the bundle branch block. For this, I have also a mnemonic rule. So, if you compare the normal QRS complexes in V1 and V6, these are the leads we have to look at. So, compared with the normal ones, you can see at the second square here, a right bundle branch block. Because in V1, it has a shape of an M, and in V6, it has a shape of a W. So if you see that in V1, it has a shape of an M, and in V6, it has a shape of a W, remember the word marrow. Marrow means right bundle branch block. If, on the contrary, in V1 is the opposite, it has a shape of a W, and in V6 it has a shape of an M, this, remember the word William. This is a left bundle branch block. Marrow and William. We have to look at V1 and V6. Then we arrive to the 8th step, which is the QT interval. The QT interval is the time from the start of the Q wave to the end of the T wave. And this represents the time taken for ventricular depolarization and repolarization. A complication of this QT interval could be, for instance, the torsade de pointes we can see at the top of these slides. The 9th step is the ST segment. The ST segment, the normal ST segment, you can see it at the top of this slide. And if it's elevated, we are talking about a ST elevation MI, most of the cases. It depends in which wall it happens. It can be septal, anterior, lateral, or inferior. We will talk later on how to recognize the different walls of the heart in a ECG. If, on the contrary, it's a ST depression, we are in the presence of myocardial ischemia. And the last step is the T wave. If we have peaked T waves, we are talking about hyperkalemia, and if we can see inverted T waves, we are talking about myocardial ischemia. In the case of patients having ventricular hypertrophy, this inverted T wave will be permanent, but it comes accompanied by big QRS complexes. So this is the map I promised to you, showing the different walls of the heart. One, if we look at one AVL, V5 and V6, we have the lateral wall. 2, 3, and AVF, the inferior wall. V1 and V2, septal. And V3 and 4, anterior walls. This is all I wanted to tell you about how to interpret the ECG. That means 10 systematic steps going from the P wave until the last part of the ECG, which is the the T waves. Now I'm going to talk very shortly about chest X-ray interpretation. So first of all, I want to tell you the color codes for a chest X-ray. Black, what we see in black is air. What we see in dark gray is fat. What we see light gray is soft tissue. Off-white is bone. And bright white is metal. These are the color codes of a ECG. You can see that the contrast between, for instance here, between the lung field and the what is under the diaphragm in the right side, the place of the liver, we can see that the contrast is very clear. Compared with this case, when the contrast is not so clear, we can see here an example of a right lower lobe pneumonia, because there is a difference in density. One of the first things when we interpret a chest X-ray is knowing whether it is an anteroposterior or a posterior-anterior approach to the ECG, to the chest X-ray. Most of the chest X-rays taken with a mobile at the different wards outside the radiology department are anteroposterior. When the patient is coming to the radiology department and we have this luxus situation, that we can done a better quality chest X-ray. And most of the chest X-rays are done under inspirium, except when we want to see whether there is a pneumothorax or air trapping, so we ask the patient to take first expirium, and then we take the chest X-ray. So how do we know whether this is done in anteroposterior or posterior-anterior view? First of all, we look at the clavicles. You can see at the example of the anteroposterior that the clavicles are above the apex of the lung fields. Compared with the other situation, the posterior-anterior view, you can see the clavicles over the lung fields, but not above the apex. The second difference is the scapula. The scapula in the anteroposterior view, you can see the inner borders over the lung fields. Compared with the scapula at the posterior-anterior view, the inner borders are seen away from the lung fields. And the third difference is the ribs. The anterior ribs that are diagonal, as you can see them at the anteroposterior view, are better visible. It's logical. And if the posterior ribs that are horizontal are better visible, that means that we are looking at the posterior-anterior view. And the last difference is the apparent, it's a false, it's not a real, but it's an apparent cardiomegaly. We will talk in a moment how to measure the silhouette of the heart in order to see whether this is a cardiomegaly or not. So when the patient is in supine position and we are taking the anteroposterior view, we will see a kind of apparent cardiomegaly. Compared with the posterior-anterior, we will not see this cardiomegaly. So, in order to assess the steps, like we talked before at the different steps for a ECG interpretation, we also have a ABC approach for the different step of interpretation of the chest X-ray. So ABC. A is two things: assessment of quality and airway. So first of all, assessment of quality. For this, remember the mnemonic word Pierre. In order to assess the quality of the chest X-ray, remember the word Pierre. Position, inspiration, exposure, and rotation. Position. Is this a supine anteroposterior or a posterior-anterior? Or is it even a lateral? Inspiration. Whether it is, if there is, if this is a view antero-posterior or posterior-anterior, we have to count the ribs in order to know whether it is in inspiration. If we see 10 or more ribs, this is a good inspiratory effect of this chest X-ray. Is it well exposed? So we have to look at the lung details, which these are very good seen here. And also we have to look at the spinal column, the outline of the spinal column that here is very good seen. That means this exposure is very good. And Pierre, position, inspiration, exposure, and rotation. Regarding rotation, the space between the medial clavicle and the margin of the adjacent vertebra is telling us whether this, if the distance is the same in both sides, that means that this chest X-ray is taken in a good symmetric position. And now talking about airway. We have to see the carina and the airway. We can see it very clear here. For instance, if the patient has a endotracheal tube, then the distance between the tip of the tube and the carina should not be more than should not be less than 2 centimeters. If it's too deep, we have to take it out a little bit, 2 centimeters from the carina. So A is airway, B is the bones. We have to look at the clavicles, look if there is a presence of fractures, osteoporosis, and so on. Look at the spinal column. Here we have the ribs. We can see the airway and the silhouette of the heart. And as I promised before, how do we know whether the size of the heart is normal or is it enlarged? It should not be more than 50% of the chest diameter. If it's more than 50%, that means that we are in presence of cardiomegaly. A, B, C. C is cardiac, D is diaphragm. We can look whether, for instance, a flat diaphragm is in cases of emphysema. Then we come to E, effusions. We look at the costophrenic sinus to look whether there is a presence of fluids, pleural effusion, for instance. The fields, fissures, and foreign bodies for F, whether there is a pneumothorax or other fissures or foreign bodies like a pacemaker, endotracheal tube, CV, central venous lines, etc. G is great vessels and the gastric bubble. So, in summary, we look at the chest X-ray, we have to know who is this person, what kind of chest X-ray is this, where it was done, when, and why. What was the reason we ordered for a chest X-ray. Then we can know whether there is rotation, if it's done in an inspiratory way, we have to count 10 ribs or more. The exposure, if we can see the structures and the spinal column. Remember that the right lung has 3 lobes, the right upper lobe, right middle lobe, and right lower lobe. And in the left side, we have the left upper and the left lower lobe. There is also the lingula. But remember that the left lower lobe is mostly posterior. And for this reason, we can only see a little part of it. We can look at the stomach and the gastric bubble. We can look at the apex of the heart, the clavicles. And finally, when we are doing all these steps, we are coming to H, which is the hyla and the mediastinum. For lymphadenopathies, for instance, if there is a aortic dissection, we can see a broader mediastinum silhouette. And just at the end, only at the end, we can reach the diagnosis and say what is our final impression of this chest X-ray. And we can see, for instance, this is a collapse, atelectasis, or a consolidation, or pneumothorax, or pleural effusions, pulmonary edema, etc. Well, we have to go a little bit faster, coming to the last point we are going to talk now, which is the brain CT interpretation. For this, I also have a mnemonic, which is blood can be very bad. Remember this mnemonic? Blood can be very bad. So blood, first of all, you look whether there is any sign of blood, bleeding, hemorrhage. Remember that acute blood is seen as a hyperdense image when it is recent. Then, after 1 week, approximately, it becomes isodense. And just only after 2 weeks, it becomes hypodense, as we can see here. So you can know the history, whether it is a recent phenomenon or something that happened 2 weeks before. Then, how to differentiate, for instance, a epidural hematoma from a subdural hematoma? Epidural hematoma, remember the eye, it has a shape of an eye because the convexity of the hematoma is like the convexity shape of an eyeball. So think epidural to remember that this is a epidural hematoma, compared with the subdural hematoma that has a shape of a crescent moon. And then you can see in this case we are in presence of a subdural hematoma compared with the epidural hematoma. This, for instance, is a intraparenchymal hemorrhage. The most common cause for is hypertension. There are different types of bleeds, for instance, intraventricular, intraparenchymal, etc. And this, with the shape of a spider, is called, it's a aneurysmal subarachnoid hemorrhage. So we said before, blood can be very bad. C is for cisterns. We have to look, for instance, in this case, the ring around the midbrain, which is the circummesencephalic cistern, whether they are free or not. Blood can be. P is brain. Look at the parenchyma of the brain, whether we can see blood. We have to look at the falx cerebri. It should be at the midline. If it's not at the midline, this is not symmetrical, For instance, look at this ventricle. These are not symmetrical ventricles. Something is happening at the other side. And hyperdensities can be blood, but also bone or IV contrast. Hypodensities can be showing us an ischemic stroke, or air or gas or fat or tumors. Blood can be very V is for ventricles. We have to look at the ventricles. Look here that we are seeing very clear intraventricular hemorrhage. And at the other side, we can see an example of the temporal horns with hydrocephalus. Blood can be very bad. The final B is for bone, for fractures. So we have to look whether the skull is in a good situation. Here we can see a skull fracture, for instance. Thank you very much for assisting to this session, and I hope it will be useful for you, not only for examinations, but also for the daily practice of medicine. Thank you very much.